once again, I thank Dr. Karthikeyan for his invite to this very cool conference that he organizes. So I'd like to kind of start with this approach to idiopathic VT, the objectives being recognition of whether the VT or the PVC is outflow tract versus non-outflow tract. Once we do that, we try to figure out where in the outflow tract it is so that we can counsel our patients better regarding the risks of their management. What are the indications if you want to intervene in a patient with an outflow tract arrhythmia, either a VT or a patient with PVCs? If you have a VT that is coming from a non-outflow tract region, maybe the fascicles, how do you localize its exit? And finally, its management. So let's begin by just taking a look at the various sites at which you can get idiopathic PVCs or VT. And most of them seem to be coming in and around the outflow tract region as a bunch, including this entire area. And then within the cavity of the ventricle, where you have the papillary muscles, fascicles, and perhaps even a false tendon there. And finally, in the free wall of the right ventricle. These are all locations of possible idiopathic ventricular arrhythmias or idiopathic PVCs. Now, one clear distinction in management and perhaps in intervention for these PVC/VT is the presence or absence of outflow tract origin. Now, when we say outflow tract origin, it means either from the RVOT or the LVOT, commonly called outflow tract. Now, the sine qua non for a PVC that is originating from the outflow tract is negative AVR, negative AVL. The QS in AVR and AVL suggests that this PVC or the VT is originating from the outflow tract. 2,3 AVF, as is commonly quoted as the sine qua non for an outflow tract arrhythmia, is usually not very positive. 2,3 AVF, that is usually not very accurate, because you can have PVCs coming from the inflow-outflow septum of the right ventricle close to the conduction system, where 2,3 AVF may be positive, but AVR and AVL will be distinctly different. So a negative AVR and AVL is the clue that that particular arrhythmia is coming from the outflow tract. Why we say that is because on the thought process of intervention, an outflow tract arrhythmia has significantly higher success rates as compared to arrhythmias which come from the non-outflow tract region. They are successful too, but they are more challenging to perform, whereas an outflow tract arrhythmia may be more amenable to a catheter ablation to begin with. So going ahead with this thought process, once we figured out that the arrhythmia is from the outflow tract, again, we look at AVR and AVL to figure out whether it's outflow tract or not. And this is the exception that I was mentioning. The AVR being negative and the AVL being positive indicates that this is coming from the inflow-outflow tract of the right ventricle close to the conduction system. You can actually make out the slur in the PVC beat, which actually contributes to a origin close to the muscle, origin within the muscle, close to the conduction system, then taking the highway into the conduction system, thereby giving you a rapid slew thereafter. So what are the factors which dispose to PVCs on a whole? It's basically characteristics of age. Higher the age, more the PVCs. Height, higher the height, more the PVCs. Exercise intensity decreases PVCs. Smoking status and ejection fraction actually increases PVCs. So when we talk about outflow tract PVCs, it's important to know what the anatomy is. So this is an ICE image from the right ventricle, where you can see the tricuspid valve here anteriorly. The right ventricular outflow tract is the anterior-most structure. And exactly posterior to the right ventricular outflow tract is the aorta. So this relationship is of great importance when trying to figure out where is the origin of a PVC when you have once decided that it is outflow tract. Remember, AVR, AVL negative is outflow tract. Once AVR, AVL is negative, you want to know where it is. Is it coming from the right ventricular outflow tract or the left ventricular outflow tract? Now, in all normal hearts, these are perpendicular to each other. You really can't see them in the same plane in the long axis. So the right ventricular outflow tract posterior wall and the right coronary sinus anterior wall are essentially the same structure. So for the purposes of origin, you generally consider them to be the same location. Slight differences exist, but more or less they are either exiting on one side here or on this side here, if the focus is in between. The characteristic anterior RVOT is right up here. The posterior RVOT or anterior right ventricular, anterior right sinus of Valsalva, and then the left coronary sinus of Valsalva, followed by the mitral annulus, which will be here. Interesting locations or unusual locations include locations from the muscle sleeves above the pulmonary valves. Care needs to be given that these locations, which are above the pulmonary valve, can be close to the left main or the left anterior descending artery. Now, going ahead, once we've got that particular anatomy, we can then take a look at the various locations within the right ventricular outflow tract and the left ventricular outflow tract. First of all, being a negative AVR and a negative AVL, suggesting that this is outflow tract. Then looking at the free wall of the right ventricle, coming from here, it's more of a left-sided structure, giving you a negative lead one. And progressively, as you go on from anterior to posterior, your lead one will keep getting positive when you are within the right ventricular outflow tract. Going on to the left ventricular outflow tract, if you are in the left ventricular outflow tract, the lead one will start getting negative. Again, the QS still remains the same. Any change in the pattern of QS has to give you a suspicion that this is not exactly an outflow tract PVC, it's somewhere in between. Now, comparing the transition of the QRS across the precordium, if you have a late transition, it's usually susceptible for these PVCs, or it's usually suggestive of these PVCs to come from the right ventricular outflow tract as compared to the left ventricular outflow tract, where the transition on the precordium is very early. Later transition suggesting right ventricular outflow tract, earlier transition suggesting left ventricular outflow tract. So how do you finesse this particular logic? What is the role of lead V1? Remember, lead V1 is not only an anterior lead, but it's also a right-sided lead. So anything coming from the anterior right ventricular outflow tract presents to you with a QS in lead V1. As we go from anterior to posterior, that is from the anterior RVOT to the posterior RVOT, going on to the left coronary sinus of Valsalva and the aortomitral continuity, the R in lead V1 keeps on increasing till it becomes a completely positive R in the aortomitral continuity. So this is an important clue for us in terms of looking at the ECG and telling whether or not the PVC is coming anteriorly or slightly more posteriorly. Remember, the precordial lead is a unipolar lead, so it's very highly sensitive to the direction of the wavefront approaching the electrode. Now, going on to lead 1, as we discussed, lead 1 essentially anything going towards lead 1 will give you a positive deflection. Anything going away from lead 1 gives you a negative deflection. So going back to our original image where we had the right ventricular outflow tract towards the left ventricular outflow tract, the right ventricular outflow tract being more right-sided anterior, whereas the left-sided is more left and towards lead 1. Anything originating from the anterior part of the right ventricular outflow tract will give you a positive lead 1, whereas as you go higher within the right ventricular outflow tract, the positive R wave in lead 1 may go on decreasing and even eventually become negative. Contrast that to a anterior RVOT location, anterior location within the coronary sinus of Valsalva on the right side, you will have a small R in lead 1. And as you go more and more posteriorly towards the aortomitral continuity, the R in lead 1 will go on being more negative. Now, there is this thought about why is it not from the epicardium? Why do you consider it from the endocardium alone? There are clues to that too. Remember, the epicardium has to have some delay before it accesses the myocardium. And that delay is seen in the time it takes to give you the peak of the R wave, also called as the MDI, where an increased MDI suggests that it could be an epicardial location, whereas an MDI that is short and relatively more sharper suggests that it could be a location within the endocardium. Why are we even bothered about PVCs? Why have I spent 5 minutes talking about them? That is because PVCs in certain burdens can actually cause cardiomyopathy. And this remains a reversible form of cardiomyopathy. If you look at the slide here, there is a bunch of reasons where you can say this is what is causing the cardiomyopathy when there is PVCs in significant numbers, but we really don't know a specific reason for it. These all seem to be contributory. So given that there is either tachycardia or frequent PVCs, these can contribute to a cardiomyopathy where removal of the offending arrhythmia or the tachycardia can actually normalize the left ventricular ejection fraction and turn it back to a normal heart. That's why it's important to know what PVCs are there and what's the burden. Sometimes, while actually looking at a lot of Holters, we end up seeing a lot of PVCs, and we don't know whether these PVCs are significant enough to do anything. The ejection fraction is normal, the patient is asymptomatic, so there is no real reason for us apparently to intervene. But according to Voskobonic in this really cool paper at Heart Rhythm, they actually showed that looking at the characteristics of the PVCs, we would be able to predict the risk of heart failure in asymptomatic patients. The composite outcomes for this particular study were cardiovascular mortality, absolute left ventricular ejection fraction decline by 10%, or heart failure hospitalization over 3.3 years. So higher the ABC-VT score, higher the chance that you will have one of these events over nearly 3.3 years. So in asymptomatic patients with a high burden of PVCs, that is generally considered to be more than 10%, estimating the ABC-VT score will give us an idea whether or not to intervene in these patients. So what is the stepwise approach to the management of these arrhythmias? The single first most important thing is to look at the ejection fraction. If the patient is symptomatic, that itself is a reason for intervention. If the patient is asymptomatic, then you look at the left ventricular ejection fraction, whether it's normal or reduced. If it is reduced, you want to look at the PVC burden. If it is greater than 10%, you offer ablation. If it's between 5 to 10%, you can consider a shared decision making. However, if the left ventricular ejection fraction is normal and the PVC burden is high, then you can use the ABC-VT score, or if you don't believe in that, follow annually with echocardiograms. If the PVC burden is low and the ejection fraction is normal, you can just continue routine primary care follow-up. Interestingly, there are only 2 circumstances where you don't send these patients to an electrophysiologist for further advice. Now, once you've decided that you want to intervene in these patients, what do you want to do? Do you want to give medications or do you want to ablate them? So for outflow tract PVCs, catheter ablation has been shown to significantly reduce the PVC burden per 24 hours as compared to any of the other drugs used. So if it is an outflow tract PVC, may be a good option for us to actually consider catheter ablation versus trying them on medications. Now, outflow tract VT or outflow tract PVCs are essentially benign unless they are associated with cardiomyopathy or symptoms. But there are sometimes PVCs which may originate from within the cavity, which may trigger off ventricular fibrillation. These are malignant PVCs and would require ablation or management of the underlying presenting feature, either in the form of a storm or continuous runs of short-lived runs of ventricular fibrillation. These require suppression, very challenging. It is gratifying to ablate these patients using radiofrequency ablation, but it's a very technically challenging procedure, often associated with abnormalities within the left ventricular cavity in the form of false tendons, or are usually close to the conduction system. The thought process is the PVC has an origin within the conduction system and a preferred exit, which gives you the characteristic PVC morphology. But because it is within the conduction system, it also has access to the various exits of the Purkinje fibers, thereby leading to multiple wavefronts of activation within the ventricle, leading to onset of ventricular fibrillation. Now, going ahead from here, let's take a brief look at the papillary muscle, or the non-outflow tract idiopathic VT. Now, these are either originating from the intracavitary structures called the papillary muscles or the fascicular muscle or the fascicles within the papillary muscles. It's usually a very, very challenging distinction to make on the basis of a surface ECG, whether it's the fascicle within the papillary muscle or the papillary muscle itself. But there is a characteristic VT, that is the fascicular VT, which is very, very amenable to catheter ablation. That is the left posterior, commonly the left posterior fascicular VT, which has got a circuit within the posterior fascicle. And these features are somewhat suggestive of it being a more posterior posterior fascicular VT as compared to a papillary muscle. Another characteristic feature is that the left posterior fascicular VT is responsive to caleptin or to maybe even beta blockers and adenosine occasionally. So it's important that we are able to distinguish the left posterior fascicular VT from an SVT with right bundle left axis aberrancy. Remember, again, the lead V1 is critical, where you have a typical V1 morphology for a bundle branch block as far as the aberrancy is concerned, whereas within the fascicular VT, it's slightly atypical.
Extremely sorry for the interruption, sir. 4 minutes left for the presentation.
Absolutely, no problems. So that is one of the critical points that we are looking at, added to which is the QRS width. Given that this is a conduction system arrhythmia, the QRS width is very narrow as compared to a right bundle left anterior hemiblock aberrancy, where the conduction is essentially through the muscle. Remember, if it's an hemiblock, you're still through the conduction system. But if there is a bundle branch block, the conduction is still through the muscle, giving you a wider QRS. The V6 R to S ratio is typically greater than 1 because the fascicle, which is exiting, is in the mid cavity of the LV, whereas for the ventricular tachycardia, it could be very apical too, thereby not giving you the characteristic V6 R to S ratio. The potential circuits, as I mentioned, could be between the right bundle and the left bundle, within the posterior fascicle, within the anterior fascicle uncommonly, or within the anterior or between the anterior and the posterior fascicle respectively. So management, acutely usually CCBs, adenosine or beta blockers, but chronic management is usually EPS RFA, where an ICD is not indicated in these patients, you would actually be able to terminate the arrhythmia successfully. In summary, therefore, the outflow tract origin of a PVC is negative QS in AVR and AVL leads. The VT morphology, similar to a typical bundle branch block, is likely fascicular VT, with the caveat that it doesn't look like a typical bundle branch, but has a RS which is not going to be greater than 1. The intervention for outflow tract PVC is in patients who are symptomatic, asymptomatic patients with decreased LV function and high PVC burden, and asymptomatic patients with an elevated ABC-VT score in the presence of a normal ejection fraction. And finally, any VT that is deemed as a fascicular VT or typical Belhassen's VT and responding to verapamil or adenosine as a clue would require referral to an electrophysiologist and perhaps ablation to help the patient get cured of this. Thank you very much for your patient listening. Thank you, Dr. Karthikeyan, once again for this opportunity.
Thank you, Dr. Deepak. That was a very clean lecture. We didn't have